This is from MedSurg, Timby, Chapter 27, Caring for Clients with Hypertension. This chapter provides information about the physiology that underlies normal blood pressure, the ranges in normal and abnormal blood pressure measurements, the consequences of sustained elevated blood pressure or hypertension, and medical and nursing interventions that help to lower blood pressure measurements to healthier levels. The physiology of blood pressure. Blood pressure is the force produced by the volume of blood in arterial walls. It is represented by the formula blood pressure equals cardiac output times peripheral resistance. So BP equals CO times PR. Blood pressure is regulated by a variety of neural, hormonal, and chemical mechanisms that either raise or lower blood pressure. The sympathetic and parasympathetic nervous systems adjust blood pressure by facilitating vasoconstriction or vasodilation, respectively. They do so by altering the diameter of the vascular smooth muscle. Baroreceptors and chemoreceptors, neurons in the right atrium and carotid artery above the aorta, stimulate the brain when there is a decrease in blood pressure or changes occur in the blood levels of oxygen and carbon dioxide are sensed. Hormones also play a role in blood pressure regulation via the renin-angiotensin-aldosterone system and the natriuretic peptides, NATRIURETIC peptides. The former, which is the renin-angiotensin-aldosterone system, raises blood pressure by causing vasoconstriction and retention of sodium ions. Natriuretic peptides have the opposite effect. So they're going to cause vasodilation and excretion of sodium ions. Chemicals such as alcohol, nicotine, and nitric oxide, NO, also affect blood pressure. The consumption of alcohol inhibits the vasomotor center in the brain, causing vasodilation, and also inhibits the release of antidiuretic hormone, ADH, resulting in lowered blood pressure and decreased circulating blood volume. Measuring blood pressure. The measured blood pressure reflects the ability of the arteries to stretch and fill with blood, the efficiency of the heart as a pump, and the volume of circulating blood. Blood pressure is affected by age, body size, diet, activity, emotions, pain, position, gender, time of day, and disease states. Studies of healthy persons show that blood pressure can fluctuate within a wide range and remain normal. Thus, obtaining several measurements for comparison is important. When measured with a standard sphygmomanometer and stethoscope, arterial blood pressure at the brachial artery during systole and diastole is expressed as a fraction. The top number is the systolic blood pressure. The bottom number is the diastolic blood pressure. Normal blood pressure for adults ranges from 100/60 to 119/79 millimeters mercury. The autonomic nervous system, the kidneys, and various endocrine glands regulate arterial pressure. Blood pressure tends to increase with age, most likely from arteriosclerotic and atherosclerotic changes in blood vessels or other effects of chronic diseases such as diabetes and renal dysfunction. Screening of blood pressure is an important method for identifying people at risk for heart failure, renal failure, and stroke. Those at highest risk are older adults, African Americans, and clients with diabetes mellitus. Systolic blood pressure is determined by the force and volume of blood that the left ventricle ejects during systole and the ability of the arterial system to distend at the time of ventricular contraction. The arterial walls are normally elastic and yield to the force and volume of ventricular contraction. In older clients, systolic blood pressure may be elevated because of loss of arterial elasticity from arteriosclerosis. Narrowing of the arterioles, either from arteriosclerosis or some other mechanism causing vasoconstriction, increases peripheral resistance, which in turn increases systolic blood pressure. This resistance can be compared to the narrowing of a tube, such as the stem of a balloon. The narrower the lumen, the greater the pressure needed to move a substance through it. Diastolic blood pressure. Diastolic blood pressure reflects arterial pressure during ventricular relaxation. It depends on the resistance of the arterioles and the diastolic filling times. If arterioles are resistant or constricted, blood is under greater pressure. Central aortic systolic pressure, CASP, the pressure of blood at the root of the aorta as blood is pumped from the left ventricle, can be lower by as much as 30 millimeters mercury than the corresponding brachial arm systolic pressure. The inference is that some are diagnosed and treated for hypertension prematurely based on the measurement of brachial arm pressure. CASP, or central aortic systolic pressure, has been measured invasively by passing a catheter from the femoral artery to the aorta, but now CASP can be measured simply non-invasively and inexpensively with a U.S. Drug Administration approved device called a CASP Pro computerized monitor. This device uses dual connections with a wrist sensor positioned over the radial artery and a cuff attached to the upper arm like a traditional sphygmomanometer. The measured blood pressure with this device is 99% as accurate as that measured with a vascular catheter. Some feel that CASP is a better predictor of future vascular and cerebral complications such as heart or kidney failure and stroke, especially in older adults with arteriosclerosis. Critics remain skeptical about the widespread use of a CASP monitoring system based on the cost of the equipment, its potential reimbursement by third-party payers, and training a technician to use it. At the present time, the majority of practitioners are relying on a conventional brachial arm blood pressure measurement. Diastolic blood pressure is arterial pressure during ventricular relaxation. It is resistance of the arterioles and diastolic filling times. If the arterioles are constricted, the blood is under greater pressure. The central aortic systolic pressure, this is a review, CASP, is the pressure of blood at the root of the aorta as blood is pumped from the left ventricle. Measured invasively by passing a catheter from femoral artery to aorta or by a CASP Pro computerized monitor gives you the most precise reading. Question: the nurse is educating clients at the community center on the risk factors of developing hypertension. Which of the following is considered at the highest risk for developing hypertension? A, obese adults, B, older adults with diabetes, C, adults who exercise twice weekly, or D, older adults with glaucoma. The answer should be older adults with diabetes, B. The rationale is screening at blood pressure is an important method for identifying people at risk for heart failure, renal failure, and stroke. Those at highest risk are older adults, African American, and clients with diabetes mellitus. Hypertensive disease. Approximately 70 million people, or 1 in 3 adults in the U.S., have high blood pressure, with only 52% having their blood pressure under control. This is per statistics from the Center for Disease Control and Prevention 2016. Because hypertension places people at risk for heart disease and heart failure, stroke, kidney disease, and the potential for blindness, healthcare providers have revised guidelines for identifying it. What once was considered normal blood pressure measurements, a systolic measure of 120 millimeters mercury and diastolic measure of 80 millimeters mercury, are now the lower ranges of pre-hypertension. According to the National Heart, Lung, and Blood Institute in 2015, pre-hypertension is defined as a systolic blood pressure of 120 to 139 millimeters mercury or a diastolic blood pressure between 80 and 90 millimeters mercury. The term hypertension, sustained elevations in systolic or diastolic blood pressure that exceed pre-hypertension levels, is now subdivided into 2 categories. Stage 1 hypertension is defined as a systolic blood pressure of 140 to 159 millimeters mercury or a diastolic blood pressure between 90 and 99 millimeters mercury. Stage 2 hypertension is systolic blood pressure that equals or exceeds 160 millimeters mercury, or a diastolic pressure that equals or exceeds 100 millimeters mercury. The parameters defining hypertension were neither addressed nor changed by the 8th Joint National Committee on Prevention, Detection, Evaluation, and Treatment of Blood Pressure in their 2014 report, but recommendations for pharmacologic treatment were identified according to age, race, and the presence or absence of diabetes and chronic kidney disease. When elevated blood pressure causes a cardiac abnormality, the term hypertensive heart disease is used. When vascular damage is present without heart involvement, the term hypertensive vascular disease is used, as opposed to hypertensive heart disease. When both heart disease and vascular damage accompany hypertension, the term is hypertensive cardiovascular disease. In review, hypertensive heart disease is an elevated essential and secondary hypertension. Hypertension is further divided into two categories: essential, which is primary or idiopathic, and secondary. Essential hypertension, about 95% of cases, is sustained elevated blood pressure with no known cause. Secondary hypertension is elevated blood pressure that results from or is secondary to some other disorder. Some people experience white coat hypertension, a term describing elevated blood pressure that develops during evaluation by healthcare providers who traditionally have worn a white coat. This type of hypertension most likely results from anxiety that is accompanied by a surge of epinephrine and norepinephrine, powerful neurohormones that cause vasoconstriction. To confirm or exclude this phenomenon, the blood pressure is measured a second time before the client leaves the agency. In cases of white coat hypertension, this subsequent measurement is likely to be normal. If the client remains hypertensive, he or she is advised to check blood pressure regularly, either at home, with the help of a family member, at a public service location, such as a pharmacy, or at the office of the primary physician. The client is advised then to bring a record of blood pressure measurements to his or her medical appointments. The exact cause of essential hypertension is unknown. Blood pressure often increases with age. Hypertension may run in families. Essential hypertension affects African Americans at a higher rate than it does other ethnic groups. Obesity, inactivity, smoking, excessive alcohol intake, and ineffective stress management are risk factors. Research into specific factors that contribute to the development of essential hypertension continues. It's well documented that hypernatremia, which is elevated sodium level, increases blood volume, which raises blood pressure. A low serum potassium level, however, actually may cause sodium retention as the kidneys try to maintain a balanced number of cations, which are positively charged electrolytes in body fluid. Scientists are also investigating the role of calcium in hypertension because serum calcium levels are low in some hypertensive clients. Essential hypertension may also develop from alterations in other body chemicals. Defects in blood pressure regulation may result from an impairment in the renin-angiotensin-aldosterone system. Renin is a chemical that the kidneys release to raise the blood pressure and increase vascular fluid volume in response to low blood pressure in the kidneys, or low perfusion in the kidneys. Renin causes the conversion of angiotensinogen, a protein, into angiotensin 1, which is then converted with an enzyme, angiotensin-converting enzyme found in the lungs, into angiotensin 2, a powerful vasoconstrictor. Angiotensin 2 stimulates the secretion of aldosterone, an adrenal hormone that causes salt in water to be reabsorbed, increasing blood pressure. Hypertension is controlled using drugs that inhibit angiotensin-converting enzyme that block the receptors for angiotensin 2 or are antagonists of aldosterone. Antagonist, remember, means against. For people with a heightened stress response, hypertension may be correlated with higher than usual release of catecholamines such as epinephrine and norepinephrine, which elevates blood pressure. Some researchers theorize that a deficiency of natriuretic factor, natriuretic, natriuretic factor, a hormone produced by the heart, results in an elevation of blood pressure because its role is to promote the excretion of sodium by the kidneys. Secondary hypertension may accompany any primary condition that affects fluid volume or renal function or causes arterial vasoconstriction. Predisposing conditions include kidney disease, a benign tumor of the adrenal medulla, hyperaldosteronism, which is increased secretion of mineralocorticoid by the adrenal cortex, atherosclerosis, use of cocaine or other cardiac stimulants, such as weight control, drugs, caffeine, and use of oral contraceptives. Specific medications may contribute to malignant hypertension. Drugs thought to cause this condition include cocaine, amphetamines, MAO inhibitors, monoamine oxidase inhibitors, MAOIs, used for depression, and oral contraceptives. Include a drug history in your basic assessment. Regardless of whether a person has essential or secondary hypertension, the organ damage and complications are the same. Hypertension causes the heart to work harder to pump against increased resistance. Consequently, the size of the heart muscle increases. When the heart no longer can pump adequately to meet the body's metabolic needs, heart failure occurs. The extra work and the greater mass increase the heart's need for oxygen. If the myocardium does not receive sufficient oxygenated blood, myocardial ischemia occurs and the client experiences angina. In addition to its direct effects on the heart, high blood pressure damages the arterial vascular system. It accelerates atherosclerosis. The increased resistance of the arterioles to the flow of blood causes serious complications in other body organs, including the eyes, brain, heart, and kidneys. Hemorrhage of tiny arteries in the retina may cause marked visual disturbances or blindness. A cerebrovascular accident called stroke may result from hemorrhage or occlusion of a blood vessel in the brain. Myocardial infarction may result from occlusion of a branch of a coronary artery. Impaired circulation to the kidneys may result in renal failure or kidney failure. Blood pressure changes in older adults may go undiagnosed during changes in life or with gradual progression of other changes associated with aging or chronic disease. Older adults should be encouraged to have blood pressure checks at least every 6 months and keep written documentation of dates, blood pressure levels, and all updates of medicines with time and dose. The American Heart Association recommendation for monitoring and recording blood pressure levels at home is helpful for those with white coat syndrome, risk factors for hypertension, or who are diagnosed with pre-hypertension or hypertension. Medication teaching must include continued adherence to the regimen when blood pressure levels have decreased to target levels, and discussion of side effects, including changes in sexual functioning, with the health care provider rather than suddenly stopping blood pressure medications. Assessment findings. Clients with hypertension may be asymptomatic. The onset of hypertension, considered the silent killer, often is gradual. It can exist for years, but be discovered only during a routine physical exam or when the client experiences a major complication. As the blood pressure becomes elevated, clients may identify symptoms such as throbbing or pounding headache, dizziness, fatigue, insomnia, nervousness, nosebleeds, and blurred vision. Angina or dyspnea may be the first clue to hypertensive heart disease. The most obvious finding during a physical assessment is a sustained elevation of one or both blood pressure measurements. The pulse may feel bounding from the force of ventricular contraction. Clients may be overweight. They may have a flushed face from an engorgement of superficial blood vessels. Peripheral edema may be present. An ophthalmic examination may reveal vascular changes in the eyes, retinal hemorrhages, or edema of the optic nerves known as papilledema, which is spelled Papilledema. Diagnostic findings. Diagnostic tests performed to determine the exact and the extent of organ damage. Electrocardiography, echocardiography, and chest radiography may reveal an enlarged left ventricle. A multiple gated acquisition scan, abbreviated MUGA, a test that detects how well or inefficiently the heart pumps, can detect heart failure that may be associated with hypertension. Blood tests may show elevated blood urea, nitrogen, and serum creatinine levels, indicating renal function problems, kidney function problems. Findings that excretory urography, such as an intravenous pyelography, which is an IVP, may further validate. Fluorescein angiography, an ophthalmologic test using intravenous IV dye, often reveals leaking retinal blood vessels. If the cause of hypertension is a renal vascular problem, renal arteriography demonstrates narrowing of the renal artery. If the cause is related to dysfunction of the adrenal gland, a 24-hour collected urine specimen detects elevated catecholamines. Blood studies reveal elevated cholesterol and triglyceride levels, indicating that atherosclerosis is an underlying factor. Medical management. The primary objective of therapy for hypertension is to lower the blood pressure and prevent major complications. Non-pharmacologic interventions are used for all clients, whether they are hypertensive or not. The same measures are continued once hypertension has been detected. Lifestyle changes include weight reduction, decreased sodium intake, moderate exercise, and reduced contributing factors such as smoking and alcohol use that may return the blood pressure to normal levels. Medical treatment with pharmacy recommendations depend on the client's age, race, presence or absence of diabetes and chronic kidney disease, and the stage of the client's hypertension. Some have questioned the new guidelines that recommend waiting to treat hypertension among older African Americans until later, because waiting places those clients who are already at risk for complications for premature harm. Table 27.2 on page 463 identifies the potential benefits that are possible with lifestyle changes alone. Currently, it is believed that in persons older than 60 years of age, reducing the systolic pressure below 150 millimeters mercury is more important than decreasing the diastolic blood pressure. Once the systolic blood pressure is controlled below 150, a reduction in the diastolic blood pressure generally follows. In clients with higher risk for hypertensive complications, as in clients with diabetes or chronic kidney disease, the goal is to reduce blood pressure to less than 140 over 90 millimeters mercury. Clients who require drug therapy may be treated initially with one drug, usually a thiazide diuretic. However, most people with hypertension will need 2 or more antihypertensive medications to reduce their blood pressure to target levels. If the blood pressure remains elevated with 2 drug combinations, a 3rd or 4th antihypertensive agent may be added. Secondary hypertension often resolves by treating its cause. When additional clinical conditions are accompanied by complications of hypertension, other drug therapy is indicated. Recommendations for limiting sodium on box 27.1. Consume less than 2,300 milligrams of sodium per day, or no more than 1,500 milligrams if you are 51 years or older, are African American, or have hypertension, diabetes, or chronic kidney disease. 1 teaspoon of table salt equals 2,300 milligrams of sodium. Because the sodium content of prepared foods can vary greatly among different brands, read nutrition facts labels to compare the sodium content. Any food that provides more than 20% of the daily value of sodium in one serving is considered very high in sodium. Prepare food from scratch without adding salt, as opposed to purchasing pre-made, convenience, or packaged foods, which usually are highly salted. Substitute unsalted, no salt, sodium-free, low sodium, or reduced sodium products for regular salted products. Choose fresh or plain frozen vegetables. If canned vegetables are chosen, drain and rinse before eating. Avoid or limit consumption of hot dogs, ham, bacon, and processed meat products, which often contain sodium nitrate as a preservative. Substitute healthy snacks, such as fresh or dried fruit, for those that are salted. Experiment with seasonings such as lemon, garlic, and onion powder as alternatives to salt. Eliminate or restrict items that contain significant sodium, such as pickles, green olives, sauerkraut, mustard, ketchup, barbecue sauce, pizza sauce, canned soup, and packaged mixes. Add to that Jell-O. Pharmacologic considerations. All drugs used to reduce blood pressure can produce dizziness and syncope, dizziness and fainting, when rising to a sitting or standing position. Teach clients how to reduce symptoms of hypotension as they adjust to their medications. Monitor angiotensin-converting enzyme inhibitors cautiously in clients with renal or hepatic impairment and older adults. A sudden drop in blood pressure may occur during the first 1 to 3 hours after the initial dose of an ACE inhibitor. Administration of IV normal saline may manage the hypotensive episode. ACE inhibitors may cause a persistent cough until the medication is discontinued. Older adults are at increased risk for development of hypokalemia from potassium-wasting diuretic drugs. Lower doses of potassium-wasting diuretics or the use of potassium-sparing diuretics can control hypertension and minimize the risk of hypokalemia. Awareness of symptoms of hypokalemia is essential. Table 27.2, lifestyle changes and benefits to blood pressure. With weight reduction, you can earn 5 to 20 millimeters mercury for every 10 kilograms of weight that you lose. Also with diet rich in fruits, vegetables, and low-fat dairy products with a reduced content of fats, red meat, sweets, and sugar, you can reduce your blood pressure by 8 to 14 millimeters mercury. Dietary sodium restriction, you can lower your blood pressure by 2 to 8 millimeters mercury. Aerobic physical activity, you could lower it by 4 to 9 millimeters mercury. And moderation of alcohol consumption, you can lower it from 2 to 4 millimeters mercury. This is on page 463 in TIMBY. Older adults may be at higher risk for postprandial hypotension owing to increased amounts of blood for digestion resulting in reduced volume available for circulation. Blood pressure should be checked following meals in the lying, sitting, and standing positions. Recommend to void prior to eating, then rest after eating to reduce risk. Pharmacological considerations. A bothersome dry cough is associated with angiotensin-converting enzyme inhibitors. Many mechanisms of action are suggested from bradykinin stimulation of the vagal nerve to increased prostaglandins. Remedies range from the addition of cromolyn, baclofen, or a local anesthetic such as Sulindac and low-dose aspirin, NSAIDs, to relieve it. Fetal toxicity is associated with ACE inhibitors. A pregnancy test should always be conducted before medication is prescribed for any woman of childbearing age. Which condiment would the nurse recommend to a client with hypertension who is on a low-sodium diet? Ketchup, lemon juice, garlic salt, or soy sauce? The answer is lemon juice. Lemon juice represents the only choice that has no sodium. All of the other choices are high in sodium. Hypertensive disease. Continues. Accelerated and malignant hypertension. Accelerated hypertension and malignant hypertension are more serious forms of elevated blood pressure that develop in clients with either essential or secondary hypertension. Accelerated hypertension is considered a hypertensive crisis. It is manifested by markedly elevated blood pressure accompanied by hemorrhages and exudates in the eyes. If untreated, accelerated hypertension may progress to malignant hypertension, which describes dangerously elevated blood pressure accompanied by papilledema. In review, accelerated and malignant hypertension develops in clients with essential or secondary hypertension. Accelerated hypertension is markedly elevated blood pressure accompanied by hemorrhages and exudates in the eyes. Malignant hypertension is untreated accelerated hypertension, and this causes dangerously elevated blood pressure accompanied by papilledema. Accelerated hypertension and malignant hypertension occur in clients with undiagnosed hypertension or in those who fail to maintain follow-up or adhere to medical therapy. Accelerated hypertension and malignant hypertension usually have abrupt onset. If untreated, severe symptoms and complications follow rapidly. Malignant hypertension is fatal unless blood pressure is quickly reduced. Even with intensive treatment, the kidneys, brains, and heart may be permanently damaged. Consequences are life-threatening when the blood pressure in the vascular system becomes extremely elevated. Some arterial blood vessels already may have ruptured or will soon. Retinal hemorrhages can lead to blindness. A stroke occurs if vessels in the brain rupture and bleed. If an aneurysm has developed in the aorta from chronic hypertension, it may burst and cause hemorrhage and shock. Cardiac effects include left ventricular failure with pulmonary edema or MI. Renal failure also may be forthcoming if the pressure is not reduced. Assessment findings. Confusion, headache, visual disturbances, seizures, and possibly coma. The sudden marked rise in BP might cause chest pain, dyspnea, and moist lung sounds. Renal failure is evidenced by less than 30 mils per hour of urine. The onset of sudden, severe back pain, accompanied by hypotension, abnormally low blood pressure, indicates that an aortic aneurysm is dissecting or has ruptured. Systolic blood pressure is 160 millimeters mercury or higher. Diastolic blood pressure is 100 millimeters mercury or higher, or both. The optic disc, the nerve, appears to bulge forward into the posterior chamber from swelling of the brain. The retinal blood vessels are obscured where they radiate from the bulging disc, making identification of their continuous pathway difficult. The retinas may show flame-shaped hemorrhages or fluffy white exudates. Diagnostic findings. Studies may reveal abnormalities include CT scans, PET scans, MRIs. Reduced blood pressure is a priority, and these neurologic tests may be postponed while emergency treatment measures are instituted. Medical management. In true hypertensive emergencies, the goal is to lower the blood pressure within 1 to 2 hours by using potent IV drugs such as Hyperstat IV, which is diazoxide, nitroprusside, which is Nitropress, nitroglycerin, or labetalol, which is Normodyne. If the client's condition is not extremely critical, other alternative antihypertensive drugs such as nifedipine, Procardia, verapamil, isopten, captopril, Capoten, and prazosin, Minipress, are prescribed for oral administration. Oxygen is ordered to reduce hypoxia-induced tachycardia. Nursing management. In true hypertensive emergencies, the goal is to lower the blood pressure within 1 to 2 hours by using IV potent drugs such as diazoxide, which is Hyperstat IV, again, nitroprusside, which is Nitropress, nitroglycerin, or labetalol, which is Normodyne. If the client's condition is not extremely critical, other alternative antihypertensive drugs such as nifedipine, which is Procardia, verapamil, isopten, captopril, Capoten, and prazosin, which is Minipress, are prescribed for oral administration. Oxygen is ordered to reduce hypoxia-induced tachycardia. Nursing management. The nurse implements medical orders promptly to ensure that the blood pressure is lowered as quickly and safely as possible. The nurse mixes drugs with IV solution carefully after carefully calculating the dosage. The nurse administers the medicated solution with an infusion pump or controller and titrates the rate of infusion according to the client's response and the parameters set by the physician. He or she checks the site and progress of the infusion at least hourly. The nurse applies an automatic blood pressure recording machine to the arm to measure blood pressure every few minutes or to assess blood pressure directly if using an arterial catheter. The nurse reports a systolic blood pressure of 160 millimeters mercury or higher, or a diastolic blood pressure of 115 millimeters mercury or higher immediately. While awaiting medical orders, the nurse restricts client activity and monitors the client closely for neurologic, cardiac, and renal complications. The nurse keeps emergency equipment and drugs ready in case complications develop. Question: a 38-year-old man has hypertension. He is interested in starting an exercise program. What form of exercise would be best for him? Bicycling, water skiing, weightlifting, or calisthenics? The answer is bicycling. Bicycling represents the only isotonic dynamic exercise, which is the form recommended for hypertensive clients. To add to this presentation, drug therapy, Table 27.1, antihypertensive agents on page 465. The category and common generic brand names of drugs used for hypertension. Diuretics is the first group. Lasix and Diuril, otherwise known as furosemide and chlorothiazide. So they decrease the work of the heart by promoting excretion of sodium in water, thus reducing circulating blood volume. ACE inhibitors such as benzapril, captopril, and enalapril, fosinapril, lisinopril, and quinapril. The brand names Zoltensin, Capitan, Vasotec, Monopril, Prinavil, and Acupril. These suppress the renin-angiotensin-aldosterone system and reduce water and sodium retention, which lessens blood pressure. Calcium channel blockers, amlodipine, diltiazem, felodipine, nifedipine, and verapamil. Brand names Norvasc, Cardizem, Plendil, Procardia, and Calin. Relieve angina by dilating arteries, improving myocardium blood supply, and reduces myocardial oxygen demand. Another group, beta-adrenergic blockers, atenolol, metoprolol, neldolol, propanolol. Brand names Tenormin, Lopressor, Cologuard, and Inderol. Reduce heart rate and decrease consumption of oxygen by myocardium and helps to prevent anginal attacks or chest pain. Another group is anti-adrenergic blockers, clonidine and prazosin, which are catapress and minopress. These relax the smooth muscle of the vascular system. Alpha-beta adrenergic blockers such as carvedilol and labatol, which are known as Correg and Trandate, relax smooth muscle of vascular system as well. Angiotensin II receptor antagonists such as azilsartan, candesartan, eprosartan, irbesartan, losartan, olmesasartan, telmisartan, and valsartan. Brand names Edarb, Atacand, Teventin, Avopro, Cozar, Benicar, Mecardis, and Diovan. These drugs inhibit the pressor effect of angiotensin II and suppress the negative feedback loop of the renin-angiotensin system to reduce hypertension. Selective aldosterone receptor antagonist is another drug used, Inspra, I-N-S-P-R-A. Eplerenone is the generic name, and this blocks aldosterone, which reduces blood pressure. Direct renin inhibitor, aliskiren, brand name is Tecturna, or RAAS, renin-angiotensin-aldosterone system. These suppress the negative feedback loop of RAAS to reduce hypertension. So the RAAS is the renin-angiotensin-aldosterone system. The drug is aliskiren, which is the direct renin inhibitor. This is the end of the slideshow.